Hi.
Yeah, thank you.
Hi, my name is Luke Buzz from Iowa City. I have a question about the ECMO training, the curriculum and everything. That was really a nice presentation, and I think perfusion should do something similar, you know, have a standardized perfusion curriculum. I know they have it in the US, but worldwide. What is the intake level for the course? You know, what kind of people are you looking for? Are you only looking? I know you said something about clinically apt, but at what level?
For the foundations course, so we still leave liberties to the institutions to make decisions on discriminating at who is entry into an ECMO specialist role. So I'd say probably universal entry. We would hear critical care experience, minimum 1 to 2 years as a bedside nurse or a respiratory therapist. But we haven't been prescriptive at this point to say you must do X, Y, and Z. But part of that's the value. What I kind of quickly went over in terms of the quality assurance with use of the exam is I think that as people take the exam and we start to learn a little bit more about the test takers and why we're asking for an application to share a little bit about your background in that, is that we will start to gain a little bit more understanding of, you know, is there a threshold for minimum clinical hours, minimum bedside experience that we should be looking for? But I don't think that there's anything right now that points to a critical minimum that we should look at. So it's institution specific at who they would be interested in transitioning to an ECMO specialist role. So it's as vague as I possibly can be on that. Sorry, Luca.
Hey, good afternoon. My name is David Aber. I'm from the Children's Hospital in New Orleans. The question's for you, Elizabeth, also. I missed your talk, and he kind of stole my question, so I'm going to embellish from that. So I know it also has the new adult certification program. Do you know anything more about the NEOPEDS aspect of that and what's being developed?
Yes. So that is the next highly sought question now that we got that out there. So, you know, what I tried to share in there is that development for the adult curriculum was about a 4-year process. And so there is individuals that are interested in helping develop the NEOPEDS. We have the framework that we use to develop the adult group. So my answer is it's not going to take 4 years, but it will take a little bit of time yet because we would like to go through the modeling that we did with using the Delphi method, getting expert consensus, whittling down learning objectives. And again, for those of you who do NEOPEDS, you understand that, you know, our adult ECMO criteria and our modules were 53. When you start getting into the different pathways of the other, you know, NEOPEDS physiology and the different disease states, we're anticipating it's exponentially more than 53 modules at the end to try to really do it justice for the other populations. But we're still a little ways out. But the intention beyond that is development of the NEOPEDS curriculum, and in concert with that, the learning objectives would be identified for an exam as well.
Susan, do you have a virtual question? Or do you want me to go with our next? We have 2 more people ready to go. Okay.
My name is Jim Patterson from Lakeland, and we do about 10 ECMOs a year. And my biggest concern, I think a lot of times, is that we fluid overload our patients. So this question is basically directed to Dr. Conrad, but any of you that I just was wondering, how aggressive are you with CRRT and taking volume off patients?
Well, at our institution, we are aggressive. So if the patient is heading towards fluid overload, we'll start CRRT primarily for volume removal, even if we can't justify it based on renal replacement therapy at that time.
We do the same thing with CRRT. We're very aggressive. If the kidneys still work and they're providing clearance, in other words, the creatinine's acceptable, the electrolytes are, we'll use a scuff mode on our CRRT machine, which is basically hemofiltration to all of you. It's just done a little more precisely using the CRRT machines. And it's really a smart way to do things. I asked my team to take off, you know, X amount of cc's per hour and still monitor the patient's urine output. If the patient was still urinating, you can still track that as an indicator of volume status. You can also track the patient's creatinine as an indicator of renal function, as long as you're not doing full replacement. So we kind of take that approach sometimes, but there's no reason to wait until you're, you know, 10 or 12 or more liters behind before you start that.
Okay, thank you.
If I add to that, if you're following creatinine measurements as a way of knowing whether kidney is functioning, are you not looking at past data, past measurements? So the kidney could be starting to function, but the creatinine could still be high at that point.
Are you referring to with or without CRRT?
I'm referring to, well, with CRRT, hopefully that's been corrected, but go
Well,
ahead, Steve, what's your point?
Well, without CRT, then that's correct. Creatinine is a late reflector of what's happening in the kidney. So there are newer biomarkers to detect acute kidney injury within 3 or 4 or 5 hours of the onset of such injury. Those are commercially available, but they don't appear to be in a widespread use. But you are right. It takes 12 to 24 hours to see the transition from an acute kidney injury to a rise in creatinine. So it's not a great biomarker for detecting and intervening early. And so following creatinine also is a little more complicated on CRRT because there is removal by the machine as well as removal by the patient's kidney. But if you're on a stable prescription of CRT, then the creatinine clearance that is being provided by the machine should be relatively stable. So any changes in creatinine would be reflective of the underlying improvement or worsening of underlying kidney function, but the creatinine itself can't be translated into a creatinine clearance.
I have several questions from the live chat. William Jones mentions, for patients requiring ECMO support post-bypass, do you fully reverse heparin with the protamine?
Yeah, that's a great question. I guess it depends on the situation, right? Like, and how bad the bleeding is. If we're worried about bleeding, we'll reverse it all the way. If not, we'll try to get down to that, 180 target in terms of ACT.
Okay, that kind of answered the next question from KMT. Do you fully reverse, or if so, when do you start a heparin infusion and what rate?
Yeah, and then so you go back to the unit, and then it just depends on your situation. If things are looking good and you're just, for example, it's like PGD after heart transplant or primary graft dysfunction after lung transplant, and things are okay, you're not bleeding, then you could start it later that night. But a lot of times, I think most of us would wait at least till the next day just to make sure we're dry.
Okay, thank you. I have another question here from Michael Lockhart. Would a femoral artery chimney graft help mitigate the leg ischemia risk for peripheral VA ECMO?
Yeah, I think it's practice specific or preference, but yeah, we have surgeons in our group that like the chimney graft. And then if you do that, then you don't need to put in a distal perfusion. And when you go to decannulate, you can just oversew the chimney graft. And so I think that's probably pretty helpful, especially in situations where the leg ischemia isn't great. So when you put the chimney graft on, you can kind of put it on and widen the artery at the same time.
Hello, Floyd Daniel from Missouri Baptist in St. Louis. My question is for Dr. Conrad. There's an article I've been reading called The Endothelial Glycocalyx and the Revised Starling Principle. Is there a practical application for us in our programs to the revision because of the glycocalyx component?
You mentioned the title of an article?
Right.
I didn't quite hear.
It's called the Endothelial Glycocalyx and the Revised Starling Principle.
And the Revised Starling Principle?
Right.
Yeah, I don't know that I've seen that article, but the Starling Principle, when first described, was based on the fact that the barrier was thought to be the endothelial cell, and intercellular junctions then became the regulator between the intravascular space and the interstitial space. And now the more current evidence is that the glycocalyx actually performs that function. So I don't think it changes the underlying principle of the underlying meaning of the Starling Principle, but I think it shifts to where that principle is actually executed in microcirculation.
Okay, and a follow-up question. this is just for my understanding, is the glycocalyx 2 times greater in the lung tissue than the vascular system?
That I don't know. That's a good question, but I don't have an answer for it.
Okay. All right. Thank you.
This is a question for whoever wants to answer it, actually, and it's something that's been on my mind. Clearly, in the Red Book, it states that if you're on VV ECMO, that you're taking out of venous and you're putting back into venous, so therefore there's no chance of overloading possibly the right side of the heart. Well, that may be true with two-site cannulation from the IJ and then from the femoral venous, but I wonder, with our dual lumens, if we're flowing at rates higher than we need to be because we're misunderstanding what hypoxemia is due to hypoxia, and we're flowing at very high rates, shooting it down into the RV, do you think, and this could be for anybody on the panel, that we could be actually overloading the right heart using excessively high flows with the dual lumen and jetting that down into the right heart, please?
I'll take a stab at that, Bill. It's an interesting concept. So on VV ECMO in general, the way I've always looked at this and the way I've described it is imagining a swimming pool that I'm taking water out of and simultaneously returning water back into it through a water hose. And I can raise that flow as high as I want. And for every drop that I put into the pool, there's a corresponding drop that I took out. So on straight VV ECMO 2-site, I think that analogy holds as you described. I feel like it probably still does for a two-site or for a dual lumen cannula, but I can't say for sure. I think you'd have to be surmising that that jet is really specific to going across that tricuspid valve. And in that case, I guess you could argue that. But I also feel like the great vessels, the superior and inferior vena cava, are very close proximity there. And I think that you're still decompressing the right atrium at the same time. And so the native flow that would be going in there would probably be less. I don't have a way to answer that factually. I can't say I've seen it clinically. And generally, we're on VV ECMO, we generally push for the highest flows that we can reasonably achieve without excessive circuit pressures or chatter or volume. But it's a great question. And definitely highlights the fact that that is a directional jet, and it is intended to direct blood across the tricuspid valve, not back into just the general vascular space. Anybody else?
I'll add something. I've done some computational fluid studies of VV ECMO, including a dual lumen, which I haven't published that data. But the jet dissipates dissipates into a cone pretty rapidly. So by the time it gets to the tricuspid valve, it's not really the hard momentum of jet that you're thinking of. But I'll echo Phil's thought is that it's equal in, equal out. ECMO systems have a very low compliance, so there's not going to be much volume change within the system. And there might be a little bit due to the tubing compliance and so forth, but it's in the steady state, once you've achieved a change in flow, you're going to see the same in and out. So I wouldn't expect any change in effective intravascular volume.
The other thing to think about is with the dual lumens is that you have the newer generation, the Protect Duos, the ones that bypass the RV. And so if you have a patient in a unique situation where they have underlying right ventricular dysfunction, that volume that you're dumping in with the Avalon or with the Crescent into the right atrium and having it go through. Sometimes these patients, and we've seen this a lot of times in the COVID population, and the use of the Protect was, has been made popular by institutions like Northwestern, where they put all their COVIDs on, through Protect. And it's that, if you have underlying RV dysfunction, that may be an instance for, figuring out a way to get that blood past it. And so I think that's a unique situation where a dual lumen dumping all the blood, it's not necessarily the volume but the location and the fact that RV isn't going to be strong enough to push it through. So we've seen it, we've done it at our institution with people who have that transient RV dysfunction, and they seem to respond to it.
Hi, Luke Buzz from Iowa City. I have a question for Dr. Javidfar, but anybody can answer. And I'm going to be very honest, I missed your presentation because I had to be on a call. I just saw your last, so this question might be obsolete, but do you have any experience or knowledge about the use of factor 11 inhibition? So that would be the anticoagulation before the common pathway, and so inducing less bleeding. And do you have any idea if that's coming to the market soon?
I personally don't have any experience with that, and I couldn't comment on its market.
Nope.
Steve doesn't know it.
Yeah.
It doesn't exist.
Yeah. You stumped us.
Elizabeth, we get these questions a whole lot out here. Sorry, I just jammed on your volume. Differences between the two current certification tests, one by AMSECT and one by ELSO, which is newer, hasn't been taken by as many people as far as I know. I don't know how many have taken it, but I know it's been worked on for a long time, and I remember 20 years ago we were trying to do one together, 30 years ago. Susan was president of AMSECT, I think. So there's differences between the two, and our good friend Jeff Riley, who passed away recently, did a lot of work on the one with AMSECT. So what do I answer to people that ask me that kind of question?
Yeah, no, it's a great question. I'd say that I don't have a lot at this point, to the point that ELSO's exam is new. I would say, and I'll be very honest too, that I'm not as familiar with AMSEC certification, you know, the design and how the questions were created. And so I probably do need to just sit and take it and go through it so I can also better explain a compare and contrast, because I as well get a lot of questions about it. What I can say is what ELSO attempted to do was just to make sure that we were very much create an exam to the spirit of ECMO. So every piece of it, the exam writers, the evaluators, the psychometric analysis, there was every cross-section of disciplines equally weighted across. And so the intention was evaluating clinical scenarios and evaluating as you come into it, irrespective of your background, because the intention was that we would all approach and come into it from a common place of that bedrock ECMO core foundational knowledge. And so in the exam, it doesn't care that I'm a nurse. It cares that I was trained on ECMO. And so I think we'll still find out. So we've had, to date, the exam launched in January. We've had about 300 applicants for the exam. We haven't done the analysis yet to kind of go back and look. But our hope is to be able to go back and just better understand. Like I said, you know, part of the impetus for this was not so much the end result. The end result is the exam, a knowledge assessment validated tool. The front end is where I think most of the passion was how do we teach and how do we evaluate what we teach, which the exam is kind of an end product to determine, did we do that the right way? So, you know, I don't know. I think that there's probably no different in my background in nursing. There's like 1,000 different certification exams I can take to enhance and to show the world the different respective areas of expertise that I have as a nurse. I think that in ECMO that there'll probably be several more exams coming to market that also have that bend to it, and they probably all have that place. And I think the individual then has to sit and read about each one to figure out what would be the right fit for them. Is that as politically correct and as nebulous as I can possibly be? Perfect.
If somebody wants, yeah, please.
Tim Bazzelli from Lynchburg, Virginia, for Dr. Mason. Do you I don't know if you can hear me. Do you have any experience with psych consults for ECMO patients? Do you think that psychiatry has a place in multidisciplinary rounds? And then question number one. And then the second one is, as you wake patients up, do you then monitor the sleep that they get eventually? And do you have any designs to make sure that patients actually get good sleep after they come out of their sedation?
Thanks. Those are two really great questions. As far as psychiatry, we occasionally, I don't typically request psychiatric consults when I'm rounding. It's not that they don't add value, it's just that I think the problems we're dealing with are too simple for them. You know, ICU delirium there's not a great way to treat it. It's mostly a prevented kind of a thing, and that really comes down to critical care related interventions and then some disease related things that we can't modify. Where I have seen my team occasionally, so for delirium, I don't think we have occasionally my team members will consult psychiatry for management of anxiety or depression. And on those, I feel like I'm a little more open to that. I don't know how valuable it is. The patients that have anxiety, you know, treatments for anxiety in the outpatient world are mostly SSRIs and SNRIs. I don't know what their role is in the ICU. Some of my colleagues start them on the patients. When I come on Monday morning, I don't stop them. I don't undo everything that was done. So if a treatment plan is in place, I leave it. There has been an association or a suggestion of increased bleeding events with SSRIs and SNRIs. I don't know how real that is, but I haven't found it to be helpful. Their anxiety is just a different variety. And I would say the same thing about their depression. In fact, I would argue most of them don't have depression. They have adjustment disorder, right? Or they are reacting to a specific stressor in their life. And so for that reason, I have not pushed hard for psychiatry consults. I wish I had better access to a psychologist to help the patients with certain relaxation techniques and other non-pharmacological techniques to deal with their anxiety. Maybe, again, not with delirium necessarily. That's where I feel like some psychiatrists are guilty of the same thing the intensivists are. We wouldn't just order a medication to solve this problem. That medicine doesn't exist. And so I don't tend to use psychiatry consults too often in the ICU for that reason. And your other question, remind me?
Sleep.
Yeah, sleep. I'm sorry, I'm so tired I didn't hear you. So sleep is so important, and we are terrible. The patient's disease itself sets them up for sleep disruption and all the medications. And then the ICU environment is horrible for that. The reason I put the x-ray example in my talk is a couple of my patients I've talked to pointed out, they said, why every morning at 4 o'clock do they come in there and put a cold board under my back? So I will tell you that that's one of the first questions. We have nurse-led rounds at our ICU, which, by the way, I think that's a fantastic business model. But that is one of the first things they always address is level of sedation, which is hopefully 0, presence of delirium by CAM ICU, and did the patient sleep last night? We ask that every single morning. I don't know that we have anything more formal than that to measure it and quantify it, but just by asking it first on rounds, you bring it to the forefront of your team's thought processes, and hopefully they can focus on it more. Thanks.
I just might throw in that critical illness, and I'm speaking primarily of sepsis, the inflammatory response, and so forth, disrupts the circadian rhythm. And I think it's a little pie in the sky to think that by going to night and day and all these other things, we're going to completely reverse that. While those things are important, they get more important as the patient's critical illness improves and the inflammation resides. So it's a tough problem to manage, and even both pharmacologic and non-pharmacologic are not going to get you all the way there.
Hi, Bridget Keeley, Winchester, Virginia. I have a comment. The glycocalyx is kind of new for me. I'm just learning how important that is. But I wanted to liken it to the tubing coatings that we in perfusion have been using for almost 20 years now. And just to say that perfusionists are kind of on the forefront and had that concept of protection at the cellular level. And it's kind of analogous to me. I just wanted to point that out.
I don't even know what that is, so thank you.
I think we have time for 1 or 2 more questions. Steve, or anybody on there, most of the programs that I go to visit, I wouldn't say most, I'd say about 3/4 of them do not measure albumin levels at all. They don't believe in it, they don't think it's important, and generally if I get them to do one, they're hypo-oncotic. I guess I used to understand why that might be not a problem if you're going through the inflammatory response mechanism, but now seeing that albumin might assist the glycocalyx in maintaining its integrity, perhaps we should be taking a better notice at that and maybe therapeutically treating it even during the entire run, if at all.
Well, my bias is that it should be taken for any critically ill patient, whether they're on ECMO or not. And I just wanted to relate an anecdote. And I know anecdotes are not evidence, but there was a patient that, and this experience has stuck with me ever since I've seen it, and is part of the reason I've been driven to not measuring, but evaluating oncotic pressure and trying to maintain it and treat it. It was before we started our ECMO program, there was a patient that was put on central VA ECMO by one of our CT surgeons. We didn't have a formal program. It was a patient who had some problems post-op, couldn't come off pump, and he decided to maintain the patient. And the perfusionist group was managing the bedside, the circuit. And the patient had bleeding, as you would expect. They were using fairly high anticoagulation levels, and so bleeding was problematic and required continual replacement of not only blood products but fluids as well. And depending on who the perfusionist was, they would fill the reservoir or give a 500 cc bolus of either crystalloid or 5% albumin. And if a perfusionist gave 500 of crystalloid, in about 2 or 3 minutes, you could see froth coming out of the patient, out of the endotracheal tube. And that would gradually subside over the next 2 or 3 hours. And then they would receive a bolus from a different perfusionist of 5% albumin and no froth. And this repeated itself for 3 or 4 days. So it was extremely consistent, and that just sunk home to me that that oncotic pressure is still critically important in these patients. But I think the answer to your question is we've not had any really outstanding prospective data. We just haven't had the kind of trials we need to answer that question. So we're looking at a lot of observational studies, meta-analyses, and so forth that is driving us in that direction. But the absence of that data has not made it clear that not everyone accepts that.
Thank you. It's time. I could go on forever with you people. Really respect all the knowledge that you've given us. I do want to remind people that, again, with this meeting, a lot of everybody's recorded session, recorded presentation is recorded on the site, the perfusion.com site on YouTube, so you can take some of these presentations back to your physicians and your care providers if you think you've obtained some knowledge that maybe you'd like to share with them that maybe you think they are not exactly in compliance with. So that's all I'll say with that, and thank you again for all our panelists. I sure appreciate that.